Morning, everyone, and welcome to Cardiac Grand Rounds for November 21st, 2023. Today we have an exciting set of speakers. We have Ryan Lee and Leslie Beaulieu. They are from the EMS side of Alberta Health Services, and they've come to talk to us about improving out-of-hospital cardiac arrest care following the data. Ryan works for EMS here in Calgary and is one of the research leads within the EMS group. Leslie is from Edmonton and is one of the communication coordinators for the firefighters and resuscitation up in Edmonton. So I think we're in for an interesting and exciting talk from a group that we probably should communicate more with. Thanks very much, Ryan and Leslie. I look forward to your talk.
So thanks for the introduction, Dr. Harworth. So we could quickly start off the presentation quickly with just a land acknowledgement here. So I would like to, in the spirit of reconciliation, we would like to acknowledge that we're gathered here today on the traditional territories of the Blackfoot, the Tsuut'ina, and the Stoney Nakoda peoples. Calgary is also home to the Inuit and Métis Nation of Alberta Region 3. We respect the culture and knowledge of Indigenous healthcare providers and to those that we deliver care to. So just to start off with conflicts of interest, I work for Alberta Health Services on the EMS side in the EMS Science and Research Department. But for the last few years, I've been a CodeStat kind of consultant with the Stryker organization. And Leslie, my counterpart here, has no conflicts to declare. She works also for Alberta Health Services EMS, but within the Medical First Response Division. I'd like to begin today's presentation by introducing you to this young fellow on the screen today. His name is Brock Ruther, and he represents a failure of the chain of survival. To quote his mother, this bumpy journey started with the story of a kind, athletic 16-year-old farm boy named Brock Ruther, her third child, who had an abnormal chest x-ray, an abnormal ECG, and chest pain that were all discarded. In May of 2012, he was playing volleyball and he collapsed on the gym floor. And what you're going to hear today is actually the actual 911 call that was presented.
Ambulance dispatch for what town or city? What is the phone number you're calling from? Tell me exactly what's happened.
We were playing volleyball. He was walking around, and I believe he tripped and or collapsed. What's his condition right now, Courtney? What's his condition? Okay, he's having troubles breathing.
Okay, this one.
Gasping breath every 5 seconds.
Okay.
No pulse.
No pulse?
No pulse.
Okay.
Weak, steady pulse.
Just one moment. Are you with him now?
Yes.
How old is he?
He's 16, turning 17.
Okay. Is he awake?
Would you pass time is awake? No, he's unconscious. Unconscious.
Okay. Is he breathing?
He is unresponsive to pain. He is taking gasping breaths every 5 seconds.
Okay. Is he breathing completely normal?
No, he is not breathing normal. He is taking gasping breaths.
I'm going to start a breathing detector, okay? Are you right near him?
Yes.
Okay. Okay, I want you to tell me every time he takes a breath starting now.
Okay.
Okay.
There's none.
There's no breath? Okay. Is he still unconscious?
Yes.
No, he just fell down. Fell on his own.
I'm sending the paramedics to help you now. Stay on the line. I'll tell you exactly what to do next.
He's just stopped breathing.
He just stopped breathing. If there is a defibrillator available, send someone to get it now in case we need it later.
Okay.
Okay, I'm sending.
Okay. We're grabbing the defibrillator right now.
Are you right by him now?
Yes, I'm right beside him.
Okay, listen carefully.
Yes.
Lay him flat on his back on the ground and remove any pillows.
Okay, he is flat on his back right
Okay,
now.
kneel next to him and look in the mouth for food or vomit. Is there anything
There's nothing in his mouth.
Okay, now place your hand on his forehead, your other hand under his neck, then tilt the head back. Put your ear next to his mouth.
An airway in his mouth.
Okay, we got somebody holding his head right now.
Okay, put your ear next to his mouth. Can you feel or hear any breathing?
Can you feel or hear any breathing? Cannot.
Okay, I'm going to tell you how to give mouth to mouth.
She is starting CPR right now. She has her courses.
She has her courses? Okay.
Yes.
Well, I want to instruct her if I can.
She's already going right now.
Okay. I'm going to tell you, and then you can relay to her if need be, okay?
Yes.
With his head tilted back, pinch his nose closed and completely cover his mouth
They're
with your
doing that
mouth.
right now.
Okay. Then blow 2 regular breaths into the lungs.
They just did that.
Okay, about 1 second each. The chest should rise with each breath. Can you tell that the air is going in and out?
Yes.
Okay, I'm going to
Okay,
tell you how to do chest compressions.
She already has on her second set.
She's on her second set.
Yeah. Can I tell you to bring the ambulance to the south doors of the school, please?
Go to south doors.
South doors. He's starting to breathe on his own.
She's starting to breathe on his own?
Not really. With assistance.
Okay. Continue.
Anybody?
Is the ambulance on the way?
Yes, the ambulance is on its way as quickly as they can.
Get on the road!
Is she still doing CPR?
Yes.
Okay. Has she pumped the chest hard and fast 30 times?
That's what she is doing.
Okay. At least twice per second.
Yes, it's definitely doing that.
Okay.
I think at this point, I'll stop here. It's really frustrating, I think, listening to this call. But I think we'll have to remember that this was back in 2012, and there was not a lot of understanding about agonal respirations at that point in time. There was not a lot of collaboration and coordination with potentially how do we introduce and use an AED. So one of the things that we learned was agonal respirations were not recognized by that dispatcher at this point. But 2012, agonal respirations were never taught to our dispatch group. CPR was delayed for over 5 minutes, and you can actually hear that kind of with the dispatcher and not relaying unconscious, not breathing, we should be starting CPR. The other thing that you heard in that tape was they went and grabbed an AED. Somebody went and retrieved the AED and brought it and put it beside Brock's lifeless body. That was the end of it. It just sat there unused for the entire time the bystanders ran the cardiac arrest until the ambulance showed up and then used the life pack monitor that was brought to them. So as you can see, these calamity of errors have spanned years because we still see some of these issues in the calls that we see coming up to more present day. And what you're finding is that calls like this result in broken families because of the loss of a loved one. But it doesn't actually just end there with the family. It's actually the whole community. And what I wanted to kind of show you is this picture here. This is one of the school resource officers, I believe, from this community. Is devastated by the loss of this child as well, because this is part of his community. And you also think about the friends on the volleyball team, the friends outside of school. All of that is touched in a small community when we talk about cardiac arrest. Now, despite the tragedy, Kim Ruther, who is the mother of Brock, has tirelessly fought for change within the out-of-hospital realm. So one of the first things that she did in terms of her patient advocacy was to change some of the language and the transcripts that you see in the 911 call. So today, we have something called Brock's Law that ensures that when an AED is retrieved, it is actually mentioned and they're actually told to deploy the AED onto that patient as well. So this is the tragic story that has driven our EMS science and research team to try to improve survival from out-of-hospital cardiac arrest. So I'd like to start here with something that everybody has seen before, and this is the chain of survival. Now, the chain of survival is essentially a system and therapy factors that comprise each link of the chain of survival, meaning that we can quantitatively measure our success or failure within each of the chains of survival. But if you think about it, if we were to take the chain of survival and just drop it in every single community, every single EMS agency and fire service, we should actually start seeing increase in survival everywhere, right? But that doesn't actually always occur. For example, the call that you just heard here. So what else do we need to ensure that the chain of survival stays strong? So what I have done here is you can kind of see what we call a frame of survival that kind of borders the chain. And these 4 qualitative factors are just as important as the hard metrics that you can work out within each of the links of the chain of survival. Now, the way it's been kind of described to me is the links of the chain cannot stay connected unless they are embedded in a context of strong medical and administrative leadership, continuous medical quality improvement, a culture of excellence, and stellar training for both our dispatchers and the frontline first responders. And that's what you see here in the frame. So it's in essence, you can sum up the frame of survival within one word, which comes out to accountability. So how are we all accountable to the chain of survival? And an EMS system that can't be accountable will only be mediocre at best. One of the things that we started when we first started our cardiac arrest journey 5 years ago is we dove into the research literature. What does research tell us for how do we improve? So what I want to start with is this, this paper here, the association between chest compression interruptions and clinical outcomes of ventricular fibrillation of out-of-hospital cardiac arrest by Dr. Tom Brower. Now, this isn't a huge study. They only had about 319 patients that were enrolled in the study that had ventricular tachycardia and ventricular fibrillation from an out-of-hospital cardiac arrest. But what he did was not only did he examine the pauses around peri-shock, but he actually went outside of the defibrillation and looked at all of the other surrounding pauses in a kind of a cardiac arrest resuscitation. And what he found was that in each pause category, I'll just kind of throw up kind of the chart here, that the longer interruptions had significantly lower survival to hospital discharge. He also found that each additional 5 seconds that were added on to the longest pause decreased the odds of survival by a further 11%. And so just to kind of quote Dr. Brower here, is our data imply that the focus now placed on minimizing peri-shock pauses should be broadened, and that similar emphasis should be placed on eliminating or minimizing pauses for all other interventions. And this would be placement of an endotracheal tube. For us out in the field, it'd be the IV or the intraosseous for IV access. And there's also when we talk about handover of care and also moving a patient from where they had their cardiac arrest and then minimizing the pause to. The next article I want to bring up here is this one. Oops, go back. Apologies, wrong arrows. This article by Dana Zai. So in this article with Dana Zai, what's really important in this one, I think it was more eye-opening for me as a frontline practicing practitioner, but this one had 23,000 out-of-hospital cardiac arrests that were analyzed during the Resuscitation Outcomes ROC trials from 2006 to 2016. And what this one looked at for the 2 kind of main points was survival by transport decision. So for patients where paramedics stayed on scene and got ROSC before transporting that patient, 28% of those patients survived to hospital discharge. For patients that we did more or less the old-fashioned load and go, for those are the ones that we quickly loaded up and for the cardiac arrest and transported without obtaining ROSC, only 4% of those patients survived to hospital discharge. When we look to like we call a favorable characteristic, so when the ambulance arrived on scene and there was ventricular fibrillation in the patient on initial arrival, but they also found that if the EMS crews stayed and worked the resuscitation on scene, if they transported after ROSC, 45.5% of those patients survived. But if they transported without ROSC, only 9% of those patients survived. So that was kind of an eye-opening thing for us over on the EMS kind of side of things. Then we have this paper by Dr. Brian Grunow, who is an emergency room physician and one of our counterparts over in the BC ambulance system. So this one's important because they're also a part of the ROC trials as well from 2006 to 2016. But before when we looked at the data, they implemented a series of changes to their EMS cardiac arrest care while they were gathering this data. And so this is kind of a summary of the trends that they saw after making these changes. And I'm just going to summarize the changes that they did. One of the changes was to maximize chest compression fraction. So again, that's minimizing the pauses so that we can have the highest chest compression fraction or as close to 100% on their patients. They asked their paramedic crews to work these cardiac arrests on scene. So we're looking at roughly a minimum of 30 minutes on scene resuscitation before they considering transporting to the hospital. They de-emphasized the placement of the endotracheal tube early on in the resuscitation and pushed it further down into the decision-making process. So what they were targeting at the beginning was an OPA or a BVM or a supraglottic airway tube early on at that point in time. And then the last one, of course, was to stay on scene roughly for about 30 minutes. And this is kind of one of the graphs that was pulled off the paper. What they found was that one of the big things by targeting patients this way, they saw a reduction in the number of transports to area hospitals. They started at about 55% of transporting cardiac arrest patients, but by the end of the study, they only transported about 50% of their patients. They saw their ROSC on scene improve from 40% to 51.4%. They saw a survival to hospital discharge that was about 8.6%, almost double to 16% study, and survivors with a favorable neurologic outcome went from about 75% to about 92% for them. So again, something that we would like to mimic here in Alberta. The next thing that we looked at is, so we have kind of two phases to a resuscitation. We have the resuscitation of the patient from collapse to ROSC, and then we kind of look at it as a second phase of what post-ROSC care looks like. We did an early scoping review a few years to understand more about vasopressors. And kind of this is I'll talk about it a little bit later on, but it's kind of an interesting look at the EMS system. So when we did this scoping review, one of the things that we learned about is to avoid the 3 H bombs, which I think everybody here is very familiar with, is avoid hypoxia in a cardiac arrest, avoid hyperventilating the patient, and then avoid hypotension. I can tell you after looking at all the thousands of cardiac arrests for AHS, we do really good on the first two. But what's amazing and shocking was we have hypotension part. We just forgot about it in post-ROSC care, which is something we'll start dealing with before. But when we looked into the research literature, we came up with these 4 main points. But what really hit us was point number C, if you look here on the screen. So cardiopulmonary rearrest may be imminent when systolic blood pressure falls below 80 millimeters of mercury and generally occurs within 2 to 3 minutes at this point. And we don't treat this in our world. And I think this is one of the challenges that we have to overcome within the pre-hospital. But we are starting to do that. One of the things, because now we're collecting data from these types of patients for our own local Alberta cardiac arrest registry, what we found is, yes, the 2 to 3 minutes of this one paper that we found is relatively similar to what we're seeing here in Alberta. Our median from ROSC to rearrest that we're finding is about 6 minutes. But what's interesting, what we found is from ROSC to when a paramedic does a blood pressure that's like a documentable blood pressure is 3 minutes. So in theory, we only have 3 minutes to deal with the hypotension before we have a secondary rearrest. And that's pretty crucial for us out into the out-of-hospital world. But we're trying to find a balance with this. And so I don't know if you guys have heard, but Lethbridge, the Lethbridge area has been doing amazing work with now integrating push dose epi and using norepinephrine as the vasopressor infusion. And some of the information, early data, but it looks like what they used to have 50% rearrest in their cardiac arrest prior to April 2022, they're now seeing less than 20% of their patients rearresting because of early vasopressor use in the out-of-hospital environment. So with the research evidence in hand, our EMS science and research team sought to understand how cardiac arrest affects Albertans through our own local research data. One of the things that we started, so back in May 2016, signed on to a national cardiac arrest study. So this is the Canadian Resuscitation Outcomes Consortium, which I think some of you might be familiar with, but we've been part of this now since 2016. So CanROC, if you're unfamiliar with it, its main objective is to be a large repository of all out-of-hospital cardiac arrests within Canada. It's to report the current evidence and guide future performance through the work of the researchers, the research physicians, on whatever studies that are going to come out looking at this. So imagine it is a database that has over 200 plus variables that we're collecting from each cardiac arrest patient. And I think currently we have over 100,000 cases now in the CanROC repository. After we kind of joined CanROC, my boss and I, so Dr. Ian Blanchard, the head of the EMS science and research team, we traveled to Seattle, Washington to attend the Resuscitation Academy leadership course. And for those of you who are unfamiliar with the Resuscitation Academy, the medical directors of the King County, Seattle response system there, they formed a nonprofit agency, the Resuscitation Academy, to teach the world literally the successes that they've had in transforming the Seattle and its area counties into being one of the most heart-safe cities. So what they produced is kind of this table here. So it's the 10 steps for improving survival from cardiac arrest. Now, as you can see here, before we went down, we kind of filled out their questionnaire. And in Alberta Health Services EMS, we had only implemented a few of these ideas, but we've never even optimized any of these things. So as you can see here in blue, one of the things before we left for Seattle is we established our own local provincial cardiac registry. But then down in Seattle, we learned about this thing called high performance CPR, which is very different from what's generally taught to us in the heart and stroke layperson CPR course. So this was a little bit interesting. I'll dive a little bit more into what high performance CPR is. And then the other one that really affected us is the yellow one there, a culture of excellence. Us in Alberta Health Services, we aren't the best at recognizing excellence, at least within our EMS environment. So these are the 3 big hits that we wanted to try to bring back from Seattle and make improvements here within their system. So we're going to start with step 1, establishing a cardiac registry. So this is what we found. Before we can make any implementations and to see how well it works, we needed to know what our starting line was or what the starting point was for survival. So using 2018, 2019, and 2020 cardiac arrest data, we've been able to figure out that from an out-of-hospital cardiac arrest setting, if you look at the green box at the very bottom, our overall survival to hospital discharge is 9.9%, which really fits that heart and stroke national average of only 1 in 10 Canadians survive their cardiac arrest. That's where we sit here. And this is only between Edmonton and Calgary zones. We didn't have the manpower to include North Central and South Central in the health zone here. Oops. But if we were to break it down kind of per year, we just brought up 5 different variables just off of the data that were collected. So the total number of cardiac arrests in 2018 was 3,309. So we captured a little bit of pre-COVID and COVID into this data. And what you're seeing here through the COVID period is we really experienced a huge number of cardiac arrests that we see in the Edmonton and Calgary zones throughout that period there as well. One of the things that you're seeing is a slight decrease in the number of resuscitation attempts on our patients when we arrive. We're decreasing the number of transports So in essence, think of it this way. We shouldn't be really transporting lights and sirens and non-viable patient to the hospital. One, I don't think it's great effective use for your time. The other one is by traveling lights and sirens out there, we actually endanger more of the population, just the way we drive and kind of that type of things. The other thing I really love is the ROSC on ED arrival. So even in 2021, you're seeing now an uptick on the patients that we're getting back in the field. And this is one of our kind of our target and our goals to improve over the next several years. Now, again, over COVID, you've kind of seen that our survival to hospital discharge hasn't been great. It's been kind of on the downward swing. But as we look into some of the future data that's not present here, we're starting to come back up. But again, ROSC on ED arrival and the survival to hospital discharge are the two main motivators on what we're trying to do within the EMS. The next thing I wanted to show you is this graph truly tells you the state of kind of EMS data across Canada. What you'll notice here is there's not one Canadian agency on the list. And that's because we're really not good at sharing. We're not transparent enough. And so where we went was to the United States. They have a voluntary data registry called the CARES registry. And that was where I was able to get the data for, I believe, 2021. So the red bar for Alberta Health Services EMS is also our 2021 data in comparison with all the 21 data from the reporting states. As you can see, we are firmly mediocre is what we are. Definitely room for improvement. Now, just another way to show you how the years have affected kind of cardiac arrest. The green line at the top is the total number of cardiac arrests that we've experienced over the years. The blue and the orange in the middle is the Edmonton and Calgary areas. And then the last one on the bottom are the three other health zones, North Central and South. You can see that in the rural, kind of the more the rural areas, it's stayed relatively consistent, but Calgary and Edmonton is starting to see kind of the bulk of the change in the number of cardiac arrests that we're seeing. Now I'm going to talk about step number 3 for high performance CPR. One of the neat thing about technology today is we can now get into these devices and pull the data out and actually see what CPR, what does it look like when a crew is performing CPR out in the field? That's, I think, the beauty of what's happening. And so the two monitors that you're seeing here are routinely in majority of the two different monitors that you'll see out in an EMS service or a fire service out in the community. So here's an example of the Stryker LifePak 15 monitor data using the Physio's proprietary software called CodeStat. So what we see here is in black, you have the ECG rhythm. Blue is the SpO2, and then the orangey yellow is the end-tidal CO2. But now we have this different green line at the very top. What was interesting for me was in the development of the quick combo pads that we stick on our patients, there is actually a slight electrical voltage that is passed between the two pads that's picked up on the monitor, which is reflective in the green impedance signal. But when we actually depress the chest in chest compressions, and if you look at kind of the right side of the graph, you can see the deflection of that wave, and that allows us to know that CPR is actually being done. And we can quantify this. And how we quantify this is I will manually go through and look at all of the peaks and valleys and understand, is it CPR or is it movement kind of in the back of an ambulance or is somebody moving the patient? And once we've analyzed it with human eyes, we are actually able to generate this. This is a report card that comes out. And I'll kind of refer you guys up to the top, to the 3 wheels that you see. We're actually able to then get chest compression or chest compression fraction. We can tell you your compression rate and your ventilatory rate for the entire duration of that call. But then a little bit down under the summary, there's a couple of points there. It'll tell you the number of pauses that were greater than 10 seconds that you had for the entire resuscitation and how long your longest pause was. So what we've done in EMS is we've taken this report card and we've been able now to give individual feedback to our frontline crews on their CPR performance. And is this amazing? So now they know how well they've done. Now, what I haven't brought up, but if you look at the very bottom, you see kind of these red hash marks called the CPR Quick View. It gives you a minute-by-minute breakdown of the entire resuscitation, so you can even see where your pauses were. And one of the nice things is it causes that self-reflection into our crews to understand, oh no, my IV was a little bit long. I shouldn't stop CPR for my intubation or for putting in a supraglottic airway. And this is one of the ways that we're starting to change how we do CPR out in the field. So because we have the data, we're going to start with the baseline. So 2018, this is where we sat with our chest compression fraction. So the two darker lines, that's where we want to be. That's excellence. The kind of lighter hash line from the 80, that's mediocre. So when we looked at the data in 2018, definitely 85% right in the mediocre category. Now through word of mouth, through presentations kind of like this to our frontline staff, Stryker has a cardiac arrest symposium that they put on, I think 2 times a year, that we actually, AHS EMS pays for the flat rate that allows every paramedic to attend it for free for the virtual sessions. Through all these different kind of mediums, we're trying to get the word out on how do we improve our cardiac arrest. And this is what you see. 2019, 2020, 2023. This is all before bringing in high performance CPR into our training. So this is a really great start for EMS. We can do the same thing for chest compression rate. For pauses greater than 10 seconds, you can see we're starting to move to the target of 0 pauses over the 10 seconds, or that are longer than 10 seconds. And the longest pause, we're actually bringing as close as we can to 10 seconds or less for the longest. So this is, I mean, this is a great sign of where we're going for EMS. We also talk about high performance CPR. So basically, high performance CPR is not special CPR. We don't do anything different. All it is recognizing that chest compressions are the most important interventions than anything else. So how do we maintain a high number of compressions and avoiding all the other pauses? And it's just coming up with an orchestrated routine when you run a cardiac arrest, but it has to be trained. And so what we're able to do, tying in with the Resuscitation Academy, we are able to fly the high performance CPR experts to train the trainer courses here in Alberta for fire services and for AHS EMS. And this is our lofty goal. We would like to have all fire agencies and all EMS agencies, which include the contract EMS providers here in the province as well, to all have high performance CPR training within the next 3 years. By the end of March 2024, all AHS direct delivery paramedics will have had this training. You can see the Calgary Fire Department will be starting in January for high performance CPR training. Leduc has already started and Strathcona County has already completed. So this would be Sherwood Park for people who are unfamiliar. So we are starting down that process. And one of the beauties of it is if our paramedics and our firefighters have the same training, when they go out onto a cardiac arrest scene, same language, same communication, we should have a far better team model for running a cardiac arrest. And we're actually starting to see that in the data. The last thing that we talked about on kind of Resuscitation Academy was that culture of excellence piece. And that's what we started here. So kind of in the military, kind of in the public safety side of things, these challenge coins are a really good item that people like to kind of share and trade. And so what our team did was we created this resuscitation coin. So you're looking at the front and back of this coin that we've created. And what we wanted to do was create categories. CPR excellence. So because we get all of the quantitative data now off the monitors, we can now recognize the top performing crews throughout the province and recognize them for their efforts. The second thing that we're doing is it's not about the numbers. So one of the things that we're looking at is we actually have access to all the written narrative on the EPCRs from our crews. So the crews that, if you get a sense when you read the call that that crew went above and beyond to try to save somebody's life, that's also worth recognizing and honoring. So those are the two permanent categories that we recognize our frontline paramedics for. We now have a third one. Kim Ruther from her son Brock has wanted to participate as well. So we've created a third category award, which is called the Project Brock Lifesaver Award. Now this one, we look at the chain of survival that I showed all the way back to the beginning, and a call needs to hit a strong chain of survival and actually have a survivor on the other end. Now, what we try to do is we try to bring that survivor to be able to meet the EMS crew that helped save their life and any of the bystanders that were also involved in that call as well. And that's kind of this one event that we hold every year on World Restart a Heart Day. So what I like to do is, this is just a little bit of a, we'll call it a little bit of an AHS EMS propaganda. It's a video from October 16th when we just had our award ceremony. So I'm just going to play that for you guys here.
Every day, paramedics perform extraordinary acts of heroism as they respond to emergencies, often in high-stress situations when every second counts.
We just tried to do our job and go home. You know, we never tried to be recognized. We just were trying to run a code well. Yeah.
ACP Wheeler, PCP McCann. You performed high-quality CPR and applied advanced cardiac life support, including intubation, for over 26 minutes.
We've given that person the best chance. We walk away from it knowing that we've tried our best, and we can not feel good about it, but know that there's nothing else anybody else could have done.
Paramedics should feel good about putting their best effort forward and giving the patient a best chance. It's not only about just overall survival, it's about trying to perform the best that you can every time. And that's what we're focusing our recognition on.
ACP Girling and PCP Sawala, you responded to the Medicine Hat College gymnasium where a 17-year-old male had suffered a sudden cardiac arrest while playing basketball.
The basketball coach met us upstairs outside and he's like, hey, this guy just went into cardiac arrest.
We did see a gentleman lying on the floor, clearly having compressions done on him in cardiac arrest. Palani and I were able to head right over, initiate compressions again, and immediately defibrillate.
They shocked him and yeah, he just opened his eyes like nothing had happened. I'm like forever grateful, and I just want to really say thank you, because my life is drastically different if they did not come into that gym.
I want to say thank you to the EMTs that saved my life, and because of you guys, I get to spend the rest of my life playing basketball.
You have an opportunity to change people's lives in this job. There's no doubt it's a hard job. The shift work is hard. The events that you undergo are hard. You can take away a lot of that stress working in a culture where people support each other. And part of the way to do that is through recognition of a job well done.
So this kind of brings it back to why everybody's kind of here in the room. And one of the things that we will see, I think, over time is that this hasn't changed throughout total number of cardiac arrests, even now into 2023. Nothing is changing that. I think we all know why. We see opioid crisis isn't really being. Still have, I think, a backlog of patients through COVID that still pretty sick out in the communities. And so I think going into the future now, at least for the short term, we're going to keep seeing the number of. The other thing that you're going to find as well is, I think, as we improve our CPR quality, as we improve how we manage our cardiac arrest, I think as vasopressors become more routine in the delivery care, you should see hopefully more patients that arrive to the hospital with versus then having the emergency department run the resuscitation. But the other thing though is, we're actually going to try to transport less of the non-viable patients as well. So that's going to be a big one. It's definitely a change for our crews, because definitely in the load and go era of our paramedics, it was hard to change to get them to stay on scene for 30 minutes. We're going to probably see a little bit of a further drop, closer to 40%. But the other thing I think that's really going to be important is the reason that we're here today is to help inform you guys today of the work we're doing in EMS, but I think further down the road, the strategy and the collaboration that we can have together can really benefit the Albertans that we deal with from both an in-hospital and the out-of-hospital realm here. So one of the things that's kind of neat is when I talked about quality improvement. So for the last 2 years, I believe, most of our patients have been having a 25 to 30 minute field. Ones that are being taken to the hospital, We're going to be working on a quality improvement project with Dr. Chip Doik out of the ICU. Does resuscitation time matter in terms of the survival? So we're getting these patients now into the ICU, but are they actually leaving the ICU into rehabilitation and eventually leaving for survival to hospital discharge? Or are majority of our patients, are we creating zombies that are just going to be staying in ICU for only a few days and then they're ending their life there? So we're actually doing a quality improvement program just to see how well this 30-minute resuscitation kind of is looking from an EMS. What does it translate into the hospital as well? The last story, I'll just kind of bookend it with the survivor story. So you saw him at the end of the video there. So this gentleman is Abeng Agot. So he represents what Brock never got. He represents, when you have a strong chain of survival, what success looks like. I think just a little bit of a background to this story is 17 years old at Medicine Hat College in the gymnasium. So a very large gymnasium, hundreds of people in the gymnasium. He arrives, he's not feeling good. He's kind of feeling like he's kind of got like, feeling like a cold is coming upon, but he's going to go play basketball because this is the all-star game. This is where, you know, as one of the superstars in the South Zone from a basketball perspective, this is his thing. This is where he gets to showcase his talent. He didn't have a great game. 9 minutes in, he hasn't slam dunked, which he loves to do. And unfortunately, he's being now switched off for another player. As he's approaching the bench, he has a sudden cardiac arrest and collapses on the floor. But amazingly, 7 people in this auditorium jump up to come to help. We had a physician and there's some coaches from the different teams, and CPR was started immediately. The referee, it turned out, was a registered PCP, even though he doesn't work for an EMS agency. He was a paramedic. He ran and got a defibrillator. They brought back the defibrillator. They used it. He was shocked twice with the AED from Medicine Hat, but did not get back a pulse. It was about 7 minutes later when the ambulance crew from Medicine Hat arrived. One shock from the LP-15, he had back a pulse. They were able to package him up. He opened his eyes, and by the time he got to Medicine Hat Hospital, he was talking. And then, of course, the way one of his coaches describes it, then he gets his free flight because he's never been on an airplane before. He gets his free flight from Medicine Hat to Calgary on our air ambulance. And as you can see today, that when his thank you video, he was in Las Vegas playing a basketball tournament. These are the stories that we want to continue into the future, and more of these success stories. Other thing I guess what I'll leave on here is that AED is kind of really important because we don't use it enough. So one of the things I didn't show on our data is the 2018 to 2020 data. We had public access defibrillator use of only 3.1% between, and that we need to kind of fix. So with that, I'm going to bring up Leslie to talk about public access defibrillation.
Thank you, everyone, for the opportunity to speak to you today. I'm here on behalf of the Public Access to Defibrillation Program. I'm a strategist with System Stat Fire Departments as well. So the AHS PAD program is a province-wide registry for publicly accessible AEDs. The owners voluntarily register into our database, which is then synced on ambulance dispatch. So that event you heard earlier where there was an unfamiliarity, existence of the AED, and there were no prompts to use it, we help ensure that the dispatchers know where the AED is, and they're included with training how to use it or how to instruct the bystanders to use it as well. In addition, to maintain the database, we also support education and awareness surrounding CPR and the importance of rapid defibrillation. Our website is up on there if you'd like to learn more about the program, heart-safe.ca. And I'm here to discuss the ways in which the PAD program has been supporting the retrieval of AED event data. So traditionally, the PAD program has more been involved in the pre-MS arrival links of the chain of survival here, as Ryan mentioned, promoting high quality CPR and rapid defibrillation. So we are now looking to support the post-cardiac arrest care by providing hospital teams with So the heart and stroke position statement on AEDs includes recommendation for data collection and evaluation as part of a. So the PAD program has been around for roughly 10 years, but has not consistently retrieved AED event data in that time. So the initiative to do so was launched earlier this year. Currently, we do provide event data downloads on an ad hoc basis, but ideally we would love to grow the initiative to the point where event data is being retrieved nearly every single time an AED is being. So some of our statistics here, currently with the program, we have over 4,300 AEDs, publicly accessible AEDs that are registered. That number does grow monthly by roughly 25 to 50 new AEDs being registered every single month. We currently estimate, based on EMS dispatch reports, that AEDs are retrieved or attempted to be retrieved over 50 times each month. We do see a big discrepancy between how many are retrieved and how many are actually applied to patients. This is due to EMS arrival on scene, so the public access defibrillator is no longer needed. In some cases, this is due to other interventions being applied, such as naloxone, or in other instances, the AED was being retrieved as a precaution for a patient who was maybe still conscious and breathing, experiencing shortness of breath or chest pain. So we do estimate roughly 10 to 15 public access defibrillators are actually applied to patients' chest every month. And of those 10 to 15, we estimate roughly half of them actually deliver a shock. So 5 to 8 times per month, public access defibrillators are shocking patients. Since the launch of this initiative earlier this year, we have facilitated over 25 event downloads from public access defibrillators. So when we did launch the initiative, it was a little slow on the uptake. We did have some concerns over both the demand and the value of this data. So initially when we started, we were downloading approximately 2 to 3 events per month. We've seen a huge increase, so we've become very popular, and now we're doing about 2 to 3 per week. So this is largely thanks to program champions such as Dr. Marto at the Mazankowski, as well as Dr. Sumner, who have been supporting the initiative and spreading awareness. So what does our workflow look like to get this event data? So I am notified through 3 different notification methods currently. We have a voluntary reporting form on the website for the owner of the AED who can let us know that it was used. The hospital care team can reach out to us and request the data. Or we do also receive dispatch reports that are auto-generated. We will comb through those and look for instances where ROS was achieved prior to EMS arrival, and we may pursue the data download in that instance. So once we find out an AED was used, we investigate, we find out where the AED came from, who owned it, and we get the owner's support in retrieving that event data. If we find out it was fire that was on scene first and one of their defibrillators was used, I can pass that request on to Ryan, who handles Calgary Fire and Edmonton Fire Department defibrillator data, as well as if there was an EMS defib that was used in the strip for an attached to the patient file, we can retrieve that as well. Once we have the AED, we provide a loaner to the site. We don't want to leave them without a working device for any period of time. Sometimes these downloads can be done on site. I can go there in roughly 10 to 15 minutes and get the download done. Other times it's a little bit trickier and I have to take the AED back to my office to do the download. In that case, a loaner is provided. For the events that happen within the Edmonton region, I can attend in person. That's where I'm based out of. For anything outside of Edmonton, I do have to use a courier service to send the loaner AED. They then take the AED out of the box, put their used one back in, and courier it back to me. So once I have that, I can facilitate the download. So the download itself only takes about 10 minutes. It's just all of the links to get that AED to a computer that can do the download. So the process can take anywhere from 12 hours to possibly several days from when the request came in, depending on how many of the issues and barriers we've encountered. I do want to note as well, we're not currently utilizing Connect Care, so we cannot directly link this to the patient's file. So we do follow up with the care team directly to find out the best way to provide a copy of this. So what do the copies of this look like? Well, here are a few examples that I've accessed recently. There are a bunch of different AED models and a bunch of different software, so it may look different depending on what type of AED was used. So these are from Philips HeartStart models. Philips models make up roughly 50% of all the registered public access defibrillators with our program. So it is a very popular model of AED. On the left-hand side, you see the FRX, and on the right-hand side is the HS1 on-site. What you're seeing here is just a brief snapshot of the event data when the shock was delivered. The AED does record the full event from the moment it's turned on until the pads are removed and the device is turned off. So when making the request for that event data, you will get the full event from beginning to end. Here we have some LifePak models. On the left, we have a LifePak 1000, and on the right, we have a LifePak CR+. This does not make up a large percentage of public access defibrillators, but they are most commonly used by rural and suburban fire departments. So in all likelihood, when requesting a fire department data retrieval, you may see one of these. Again, this is just a brief snapshot here. And then here we have Zoll AED models. So both of these are from two separate events from Zoll AED pluses. And these devices do actually have the ability to measure CPR performance metrics. So you are looking at layperson bystander CPR performance there, as well as ECG on the right. And Zoll models make up roughly 1/4 of all of the publicly registered AEDs. So as I mentioned, sometimes it can take several days or longer because of some obstacles in our current workflow. So I do just want to be fully transparent. We do everything we can to get the data, but sometimes everything doesn't cooperate with us. So the notification system is not necessarily clear and consistent. As I indicated, there are 3 different methods, and some of those are not necessarily in a timely manner. For example, the AED owners submitting a form indicating the AED has been used. Sometimes it takes them several days to kind of wind down after the event and actually communicate that to us. Technological barriers. So our fantastic IT team with AHS has a lot of barriers or a lot of safeguards in place to protect the AHS network. Unfortunately, those same safeguards do not work in our favor when trying to retrieve AED data and to link to external devices. So sometimes we do run into issues there. Minimal staffing, because of the difficulty in accessing the software and the hardware, we do have minimal staff who can facilitate these downloads. Lack of awareness. A lot of departments don't know that the PAD program exists, let alone what we're able to do, but we're here addressing that today. The courier system is mostly reliable, but sometimes fallible, so there can be delays, particularly with weather issues in the AED actually being sent out, and the AED variables. So having a look here, there are 6 different manufacturers with over 20 different models of AEDs approved for sale by Health Canada. So each model has its own proprietary software and hardware to transmit the data. It does usually require infrared data transmission, which is a notoriously finicky and difficult data transmission method to work with. Software is often provided at no cost, but in some instances, the manufacturer does charge for the license. And then the cables you see down below are just some of the different types of cables we need to have to be able to access all of these different models of AEDs. And those cost anywhere from $50 to $200 a piece. So we have not seen a lot of studies. We have seen this real world insight into public access defibrillators over 5 years. This study was conducted by HeartScene, which is an AED manufacturer owned by Stryker. The data was collected between October 2012 and October 2017, where responders voluntarily submitted the electronic data downloaded from their HeartScene public access defibrillators. They did also fill out a form with patient demographics and other case information. And this was done in exchange for a free battery and electrode pack replacement. So there was an initiative for the AED owners there. The data was collected from 977 patients internationally. Of those 977, 40 were instances of out-of-hospital cardiac arrest within Canada. So this was the first analysis of data that was self-reported by the lay public. So it did give major insight into public access defibrillation and presents an effective method of collecting post-market clinical data follow-up. So our program has a similar methodology in that we follow up with the AED owners. We do offer mental health support. We offer troubleshooting and maintenance. And we do offer to reimburse the cost of replacement pads as well. And at that time, we make the request for extracting the data off of the AED. So in this instance, survival was measured to hospital admission, but we do see a confirmed survival of nearly 65% for patients in a shockable rhythm when the AED was delivered in less than 5 minutes. And here we see for response times greater than 5 minutes for the AED for patients in a shockable rhythm, it was approximately a 44% survival rate. So currently there's limited studies that are conducted on lay responder AED event data. They're primarily focused on healthcare and emergency responder information. So with the event downloads that we are now accessing, we've been able to get insight that was previously unavailable to us. So with those barriers I mentioned, we are working hard to overcome them. We need to set up a more immediate notification system for we are working on, and communication needs to be disseminated through relevant departments. So as I mentioned, we are here today spreading the word. We do need additional support from IT as well to enable a software access on more computers for more staff. And then we do need to recruit additional staff and volunteers to facilitate those downloads, particularly in certain regional areas, so we don't have to utilize that courier system. As the initiative and the program continues to grow, that's part of why we're here today, and we are looking for feedback and suggestions, ideas, questions, concerns, anything. We will have our contact information up here to reach out and follow up with us, or if you would like to request an event data download from an AED. Are there any questions?
Very much. That was fascinating. Thanks. I have a quick. So we will throw it open to questions. I think I see a couple of questions coming from our electrophysiologist. Okay. Big Haas and then Steve.
Sure enough. Thanks, great presentation. And when I was in med school, I did a few of the ambulance write-outs. You quickly realize that, we're pretty lucky. We live, work in very controlled environments with sick patients where, when you go to the scene, there's a patient, but there's also family and, weird environments and things. So appreciate all that you guys do. Two questions. So the first one is, I know there's US data showing that the characteristics of the cardiac arrest are changing. You're seeing a lot more PA and asystole. So your resuscitation is probably going to be less than VF and VT. I assume that's probably true in Canada as well.
So one of the things with a lot of the data that I showed on ours. Yep. Over here. Okay. One of the things with the data that I presented, it's actually all of it. So asystole, PEA, and ventricular fibrillation are all combined. We actually haven't separated to look at PEA and asystole together and then VF on its own. We've just morphed them all together. So for a lot of the survival numbers, think of it from that perspective. We do know that our VF survival is higher, but it's just, again, it's time versus kind of the work that we're doing to be able to run more of the full analysis. Because when we talk about manpower, for what Leslie was talking about, our research team is one PhD who functions as our data analysis, and then kind of the 3 paramedics that work with them. So we do about 6,500 cardiac arrests a year. So try to be able to input it into the database, then run the analysis. We're trying to catch up. But that's kind of an idea, which is where the data is going.
Now that you're retrieving a lot of the AED data, like I always kind of worked on the assumption that if you had a cardiac arrest and somebody did CPR, somebody put an AED on, you found a rhythm to shock and shock you out of it. Probably 99% of the time, it's probably VF or VT. Maybe you could have pre-excited AFib, but you're not going to be able to figure that out. Is that kind of true? Are there other things that maybe I'm not thinking of, or somehow it responds the same way and people get shocked and get out of it? I can't really think of too many. I don't know if that's what you're finding. The data is actually, the AEDs are pretty good at doing appropriate shocks.
That, I think I'll say, is more of a manufacturer kind of idea about how they build the algorithm. Because I don't really know exactly what how the manufacturer programmed their algorithm to verify. I would say, as long as it deems shockable for the public access defibrillator, it will then go through its setup to charge the monitor and to allow that defibrillation. We have one instance with a Calgary Airport AED where I don't know if it was a cardiology colleague, but it was a physician colleague. He witnessed a gentleman collapse while standing in line for check-in at, I think it was on the WestJet side. When he went to go help him, he was still conscious, breathing and talking, but prophylactically, he attached the quick combo pads on the public access defibrillator that was brought to him, the monitor charged up and said he's in a shockable rhythm. And so he defibrillated him. So we'll call it a poor man's cardio version. But when you actually look at, so we were able to retrieve that AED data, and definitely, in fact, he was in a ventricular tachycardia, but still conscious. And once he defibrillated, he actually went into a sinus tachycardia that actually improved. But again, I think it's because the knowledge and kind of the information was there versus a complete lay bystander. Because the lay bystander, I don't think would have even come close to doing what he, but it has, the doctor did save his life. And prevented him from going into cardiac arrest.
But it does ask initially, are they unresponsive, right? But
not on an AED, no.
Oh, not on the AED. Oh,
No.
okay.
I think it is the assumption is off the start that you are putting it on an unconscious, not breathing person.
I just had a bit of a question about the data. So I think you partially answered this. So you're including all causes of calls for cardiac arrest, including opioid poisonings and things like that. That's going to obviously change.
Yes, like, I mean, so in the variable list, we have a section for cause of cardiac arrest. Now, there's a big, you can put a big asterisk to it because we don't actually have access to medical examiner reports for the individual patients. So we're going off of the impression of the paramedic on what was the cause of death. I think at least 60% of the time it's a cardiac relation, but some of the different annotations that we have for it are, we have traumas, so we'll do like hangings, there's exsanguinations, depending on what that is. Drug poisonings. Drug poisonings are not isolated into opioids, methamphetamines,
Right.
but it's just one big category. But one of the beauty of what we've done is CanROC has delivered, I would say, a basic list of variables that we are going to be collecting for the CanROC study. But we've used an Excel spreadsheet for abstraction of the data. And by doing so, we can actually further dive into the variables and create our own variables from an Alberta local point of view. So one of the things that we did from a drug perspective is we actually now have a specific opioid category that we will also track just for our own knowledge here in Alberta. We've also done that with fire department AEDs. The data from CanROC wasn't clear in having a clear separation from EMS and fire. And so what we've done is we've kind of made that own separation, just because if you look at the city of Calgary, for example, we're not the same entity. They're two separate agencies. And so we want to be able to collect the data more corresponding for what we know of EMS and what we know for fire.
I have a number of questions coming up on the chat. So
we do. Oh, so Dr. Preer. Yes. That's a great question. So Dr. Preer talks about to make a comment on mechanical CPR device and is AHS looking at their use in the field? This is a great question. So there's two lenses that we look on for mechanical CPR. And one of the lenses comes from a lot of the research studies that's being found. So when we look at the research studies, mechanical CPR in relation to manual CPR actually has no statistical difference in survival to hospital discharge. So from that perspective, no mechanical CPR devices in a large urban setting probably is not very good. But the other lens that we need to actually apply is what benefits do mechanical CPR bring to the actual providers. Now, this is where you think more of rural settings, suburban rural, where you have longer transport distances and potentially less manpower that can assist in the cardiac arrest. And in that setting, when you're not looking at patient outcomes, that's probably one of the best places to put mechanical CPR devices, because what it does is it frees up, I will say, some cognitive load off of the practicing paramedics so that they don't have to focus on CPR quality, but then they can think more of like the 5 H's, 5 T's to figure out more of the origin of the cardiac arrest and treat that. I'm hoping, Dr. Preer, that's answered your question. Oh, and yes, AHS is looking into mechanical CPR devices, but more for comment number 2 versus the research behind it from the patient outcome.
Dr. Hanrahan, who indicate, Dr. Hanrahan, that one of the barriers to a program is that the majority, 85% of cardiac arrests are happening in private residences. So attempts at crowdsourcing AED are excluded private residences. How can we as providers address this narrow concern about privacy of life. So this is my area. So this is something we are looking into currently in regards to crowdsourcing bystanders in CPR. We don't have the direct answer yet, but I can definitely say we've thought about it from several different angles, including a tiered response method, such as verified responders of a higher response levels, such as confirmed healthcare staff, paramedics, things along those lines, who are vetted to ensure that they can enter private residences. Or in addition to that, could be as simple as we ask them, we're on the phone with either the patient themselves as they're starting to experience something, or we're on the phone with their bystander who is calling, and we ask their permission. I have CPR trained responders available. Do they have your permission to enter the residence? So we've considered a few different aspects, and I don't have the definitive answer to that yet, but hopefully some of those will be able to address those concerns of sending lay bystanders to assist with CPR in private residences.
So we're running a little bit over, so I think we'll need to close the session. Lots of questions coming in. Thank you very much. That was wonderful. And thanks for coming. Hopefully we can have you again sometime.
Thank you very much. For anybody who would like to reach out and request a data download or do any additional follow-up, our contact information is here. Please feel free to reach out to me with requests, and I can forward those on to Ryan if that's within his department. If you are requesting an AED data download, the EMS event number